No, I'm doing that. Otherwise, how am I going to the next slide? I'm clicking on the next one. Tell me now it is not moving. It is not moving. Okay, I think, I would not, for the sake of time, I won't repeat whatever has been gone, but I feel things should have been better organized. Someone should have looked at the screen and ensured that these two are synced. It is very unfortunate. So this is actually the topics that we're going to be covering. And I have already mentioned that I'll be talking about the SOPs that I follow. And my SOPs basically depend upon what refractive outcome I'm getting in this particular year, and then what are the new things that have come up in the literature, new suggestions and new tips, then I incorporate them. So my first tip would be, please ensure that don't consider IOL power calculation as just a one-off event in the workup of the cataract patient. It is something which pervades the intraoperative period as well as the postoperative period. And ocular surface, we have realized for the last couple of years, is very, very important in this context. And if the ocular surface is suboptimal, and it may result in poor refractive outcome, both in terms of more monofocal or multifocal IOLs, or toric technology where you get a wrong axis and wrong IOL power. So it really messes up with your postoperative outcome. So if your patient has an ocular surface issue, that has to be optimized, and then biometric readings have to be taken. Third point that we do is, we never do the biometry on a cornea which has already been, where procedures have been performed, where you have dilated, we have done an ablation tonometry, or any contact technique has been used. So that should be done as the first thing in the morning for the patient. I had realized that when I was doing ultrasonic biometry, in certain cases, I won't get a good value if I don't dilate the pupil. So I have been dilating those patients when I used to do ultrasonic biometry. Then recently I found out a paper where it has been recommended even for those who are using a SOPs OCT-based optical biometer. So this particular study, this is with IOLMaster 700, 8.52% of cataract surgery candidates had preoperatively low quality biometric measurements because of dense cataract. So these were dilated, and repeat axial length measurements improved. The quality improved in 75.95% of the patients. So sometimes, if you don't get a good quality measurement, I would dilate and then do the readings. But another picture comes into the mind. Whenever an eye is dilated, the biometric parameters are known to change. So multivariate formulas, like all the modern formulas, they may give different results. See, there are plenty of articles, plethora of literature. So after dilatation, if you see carefully here, the central corneal thickness increases, the anterior chamber depth increases, lens thickness comes down. So if we use the biometric parameters obtained after dilating the eye in the modern formulas, you are expected to land up in calculating a lens which is half to 1 diopter higher. So patient will have a myopic outcome. So I always tell these patients that I'm dilating your eye, and for me to get accurate results, but in 25% of the time, I may be off the target refraction, a myopic error by 0.5 to 1 diopter. So a patient is counseled accordingly. And sometimes when you don't get good Myers, in particularly patients who have ocular surface disease, you thought you have optimized well. So we are in the habit of putting a lubricating eye drop. It is a universal phenomenon. So if you are doing that, then you use a time period of more than 5 minutes after you have instilled the eye drop to repeat to get the biometric parameters. Now, what are the devices that one should be using for obtaining these biometric parameters? I use an optical biometer. I also use a topographer and eye trace And always make sure that if the patient is using a contact lens, that has to be removed at least 2 weeks if it is a hard contact lens before the biometric procedure. A manual keratometer, an auto keratometer, or such devices definitely are also, they give very good results. Please do not use immersion A scan, the contact A scan. If you're using ultrasonic biometry, use only immersion A scan, because we know that the results with immersions with contact apprehension biometry, ultrasonic biometry is much less accurate. There's a mean average shortening to the tune of 0.25 to 0.33 millimeters. So this is a meta-analysis done by the late Hygis, where he compared optical biometry results versus immersion, and they found out that optical biometry still gave better results in terms of the post-operative prediction error. The optical biometers have been improving. We have now new generation, which are SOPs or OCT-based biometers. Those of us who are still using the older ones, so then I use the ILMaster 500. I've been contemplating whether to change to a higher one or not. But those of you who are using the basic ones, the studies have shown, various units have been compared, and they have shown that, they are quite, there's got great deal of repeatability and agreement between the different systems. So it really doesn't matter which biometer you're using. And if you're using, whether to step up to ILMaster 700, there's an article about 9 years back which showed that, both those devices do extremely well in terms of the accuracy and predictability. However, ILMaster 700 has certain additional features: harder cataracts, posterior subcapsular cataract, lens tilt, and then, you know that you're measuring up to the fovea. So these are the posterior corneal measurements. These are additional features that the machine gives you, but ILMaster 500 is also pretty much accurate. Then another thing we need to bother about is, just because one is using an optical biometer does not mean that you're going to get fantastic results. There are validation guidelines for each biometer, and these actually are very, very, they're very important. They're a little complex, so I have taken a printout. It is in the optical biometer room. So whenever the validation guidelines are not fulfilled, that particular scan has to be deleted, and the examination has to be repeated. Hard cataracts, optical biometers like, ILMaster 500 doesn't do well. So if the fellow eye has a immature cataract or a pseudophakic eye, I do an immersion scan as well as optical biometry in that eye. And if there is a good degree of correlation, then I assume that, my ultrasonic biometry, immersion biometry for the hard cataract eye is more or less, reproducible, and I repeat it once more and then accept that value. There are newer and newer formulas that have come up, and we have, the current formula is Hoffer QST, which is actually uploaded in the ESALS website. So I basically still stick to Barrett Universal 2 for my routine cases, because it is a suite of formulas. All refractive requirements are taken care of by this particular formula. This also can be used if you have used an immersion A scan, or even a contact A scan with ultrasonic biometry. Only thing is, the A constant has to be proper. It will be written on the box what should be A constant that should be used for ultrasonic biometry if you have done the contact biometry. So this has to be kept in the mind. Kane formula is a new kid in the block. It does well for a variety of situations. I use multiple formulas when I'm dealing with extremes of eyes, short eyes, long eyes, and things post-vitrectomy eyes and things like that. So it has given me good results. I find that it is better to use 3-4 formulas in these complex situations and find out what exactly is the ILPA that I should be using. Make sure that the rexis is always central, and it has a uniform overlap on the optic margin. And if a patient is coming for surgery for the fellow after a couple of weeks, I take advantage of the refractive error that has happened in the eye that has been operated. So there are certain conditions that have to be fulfilled. Both the eyes should have interocular symmetry and few other conditions. So I would adjust the target refraction for the fellow eye to the opposite power, and about 30% of the Barrett's Universal to whatever I get with this. So this is an adjustment that I made. And newer formulas have second eye enhancer. Gender also plays an important role. Barrett Universal 2 is supposed to be more accurate for males, and the remaining formulas are more accurate for females. So this is also being taken into account in the newer formulas. So friends, the SOPs keep changing, and but you need to be always abreast of the newer developments that are coming up. Use validated measurements, work with properly optimized lens constants, adapt to new technologies as they present, employ the right formula, and strive to use all available resources to their best advantage. Thank you very much for your attention. So, Kumar, you are going next. Yeah. Oh, I'm so sorry.